Welcome to InnerSight, Health Optimization with Rudy and Shaun.
Okay, here we are, podcast number 15. Shaun, it's been good. It's been good. We've had some great feedback from our previous podcast, and it's great to have another colleague here today to learn from. I think our biggest listening has been coming from our Iron podcast. So if you haven't listened to that one, please go and listen to the one with Brooklyn and Lowe. That's been amazing.
That's been a good podcast. I'm very glad to have Marlena here today because, that saying of men are from Mars and women from Venus. So in our practice, we see a lot of men, okay, but we're starting to see more and more women. And hence, why are you sitting across from us tonight? Because we need to learn to deal with it. But
so Marlena is actually a colleague. She's an obstetrician and gynecologist from northern suburbs of Cape Town. She was actually in our class as an undergrad, so we were all three in the same class, undergrads, and we've all been in different areas. She's actually branched off into a side of gynecology that she's going to tell us now about. She's written some books. So Marlena, maybe I'll let you guide us on how your journey went from being just a normal obs and gynae, or OBGYN as the Americans call it, to where you practice now.
Thank you, Rudy and Shaun, for the opportunity to discuss one of my favorite topics today with you, and that is everything I know and care about when it comes to hormones. So yeah, like you said, I'm a gynecologist. I've been in private practice for the last 15 and a half years. And for the first 10 years, I managed many pregnancies. And as a sideline, I would say I took care of the gynecological health of women. And in the first 10 years, I realized how little I know after I've specialized, that menopause is just not something that you get taught while you specialize in the 4 years of doing your MMed. And the other thing I realize is the lack of knowledge, not just from gynaes, but from GPs, from patients. There's not a lot of information available, or there wasn't until very recently. And apart from just the gynae side of my practice that was not so prominent, I also realized that there's such a big need for advice and care in the field of sexual health. So I've, in 2018, took a big step after 10 years to hang up my obstetric boots. And for the last 6 years, I've been taking care of women from a gynecological point of view, as well as their sexual health. So yeah, that's where I am. And I'm really enjoying what I'm doing, and I'm learning quite a lot in this whole new journey. It would be lovely to share that with you.
I think that's great. I think exactly what you're saying. I mean, from when we were undergrads, very much the same as with our own podcast, HRT or hormone replacement therapy has changed so much, and that is why we are talking to you, because there are loads of women out there that is in the spectrum from when they started their menopause or started to menstruate, and they are somewhere in this journey to where they finish menstruation. And what do they need to do? Where do they see themselves? And when they see these little values on a blood test, what does that mean?
exactly. And I think there's also a lot of confusion out there, especially with the Women's Health Initiative. And we'll spend some time on that later. But that caused a lot of problems in what do you need to do hormonal-wise.
Yeah, absolutely. That is quite true. We need to talk about the WHI and breast cancer and HRT.
Shall we just maybe start from the beginning and just discuss what the normal cycle looks like?
It's so interesting how men and women differ. Men produce sperm every day, and the sperm cycle, as far as I know, is about 6 weeks. So every 6 weeks, there's a fresh batch of sperm. Women, little baby girls, is born. They're born with all their the follicles on board already. So when they're born, all women has got about 200 to 300,000 follicles on board, stored in their ovaries. It rests until menarche, puberty hits, and then in a very cyclical way, every month, it's organized and controlled by all the hormones coming from your hypothesis, and it speaks to the ovaries, and it's a regulated cycle. So a normal cycle lasts 28 days, and it's cut into half. So I often think of it as a sports game, that there's a half time in the middle, and that's kind of the ovulation part. So in the beginning of a cycle, there's around 35 of the follicles that's recruited for this cycle of the month. So from the batch of follicles that you have, 35 comes together, and their main aim in the first 2 weeks is to produce a Gravian follicle. And the dominant hormone in the first half, your follicular phase, is estrogen. And under the influence of estrogen, the endometrial line, after it had shedded the first, the previous cycle, it starts to build up in the endometrial line in the uterus. It starts to build up. And at the same time, you get the maturation of the follicles. And the aim of the follicles is to produce this Gravian follicle, which is going to ovulate once there's a spike in your LH. And after ovulation, the whole game plan kind of changed for the second half of the game. Yeah, there's a new coach and there's a new captain.
Bomb squad.
Exactly. The dominant hormone in the second half is progesterone, and progesterone remains fairly stable until day 26 normally, and then it drops. And in the uterus, the endometrium that has been prepared and actually becomes quite rich with metalloproteins and natural killer cells. Quite an interesting, a lot of things in there. It's not just blood that comes with menstruation. It was quite fascinating for me to find that out, and to realize how much of that one can use to treat patients with bleeding abnormalities. Anyway, yeah. So in the endometrium, the progesterone in the second half thickens and enriches the endometrial lining, and prepare as if you are going to conceive and receive an embryo. But if that doesn't happen, with the drop in progesterone, there's the start of a new cycle that is being introduced with the menstruation. So that's in short what a normal cycle looks like.
Yeah, most of the girls out there can attest for that. I mean, they start menstruation somewhere between 10 and 13, somewhere there, and then we'll have a cycle, or we'll have irregular or irregular, we'll have a cycle or a type of cycle, even though they don't know how the hormones are in their body, and they will have different types of symptoms, premenstrual, postmenstrual, and so I think we should maybe move on and say maybe just something about contraception, how that affects that, because we're aiming to get to HRT, but we just have to fix how this first part of womanhood.
I think it's so important to remember when you go on contraception, you actually switch off the function of your ovaries. So sometimes or often I refer to contraception as a piggy bank. You save on follicles because you do not ovulate on when you're using contraception.
That's a very interesting fact.
It is, and there's a misconception around that out there. You do not ovulate, which is a good thing.
I mean, one of the concerns is that if you go on contraception, will you be fertile later on if you stop your contraception?
Exactly.
I think that's one of the main concerns.
So the point
people.
is, yes, you will. And all the contraception that we had, apart from the Depo-Provera, is short-lived. The action is short-lived. With a pill lasts for 24 hours. So many women can still fall pregnant whilst using the pill. If you don't use the pill correctly, and that's an indication that it does not really affect fertility. And the other thing is the protective effects of the pill. If you're on a monophasic pill, meaning that you have 24 pills that's got the same dose of estrogen all the time, there is no association with breast cancer. If you are on a triphasic pill, there is a small association with breast cancer. And most people these days are on monophasic pills. It actually prevents colorectal cancer, the use of the pill, and the contraception also prevents ovarian cancer because you do not ovulate every month. So there's not that healing effect where things can go wrong. So there's lots of positive things that one can see that comes from using the pill. So usually I don't like to start young girls until the age of 16 on the pill. I want their hormonal axis to form properly. There's other ways how one can deal with heavy bleeding, or especially if they become iron deficient, because I do see that very often. But yeah, if we start women, if we can start them on monophasic pills, I think we will. If we can get them to understand that's actually good for their health and beneficial, we will definitely make a
I
difference.
suppose that's the most common reason why they come and visit you at that age.
At
is
that
for
age. Yeah, to
excessive
discuss.
bleeding.
And we have so many options available these days that it's actually nice to be able to provide young girls with options where they don't have to take the pill. They can use intrauterine devices that contain safe hormonal depot amounts.
Oh, that's very interesting. I didn't
And
realize
the
that you
ring-
save your follicles.
And it's also a lot of the people listening will be mothers, and,
Yes.
and there's a lot of pushback from the mothers. No, I don't want my child on contraception at 16 or 17 or 18. And I think that's quite nice to hear that it's actually good for your health.
It's actually good. Yeah.
Yeah.
I will never use preventing ovarian cancer as an indication to start contraception, but it is an added benefit.
Of course, you're going
Yeah.
to start contraception if there's an indication for it. I mean,
And indication is not just always sexual activity preventing pregnancies, but it could be skin or heavy bleeding, skin issues, heavy bleeding that we need to control. It's just so much easier to do it with a combined oral contraceptive pill than giving them separate hormones to take, especially if they're in the, adolescents or young students that doesn't have a routine, so there's so many options that we can use to make life easier for them.
Amazing. Okay. Let's push forward with the timeline. So now we've got someone either on contraception or have had all their babies. So they will be in some type of a cycle, and they will then be, let's say, 32 plus. Where do they need to start thinking now? Like I said, we're moving towards HRT, but how do women think about this?
32 is sometimes the age where women only start their fertility careers. Let's just be honest about that. The interesting point that I've recently learned is that a woman is most fertile age at age 25. Now, people's not ready to have children at age 25. So a fertility group specialist has reached out to gynaes to speak to patients about this and to discuss egg cell storage and to discuss that at least with patients, because it's available in Cape Town. I think it's from 35 onwards that one's body starts to change. The first hormone actually that starts to decrease is testosterone, and followed by that is estrogen. And it is interesting to think that in your body, cholesterol is the primary building block of hormones. Followed, and from cholesterol we get testosterone, and from testosterone estrogen is derived in all its three forms. And I think that's quite important to keep in mind as we talk about aging of women.
I've got a question on that one, is that sometimes we see older women, and then when you test their hormones, sometimes there's a testosterone test also included. Does it make sense to do a testosterone level at an early age, like in their 20s? To have a comparison when they're older, or not necessarily? Because we don't really have a reference range.
There's not a lot of work that's been done. And that's I think there's a lot of movement in that direction. Recently, I think in 2020, was it 2020? We only had the first guideline published on the use of testosterone in postmenopausal women and proper indications for that. Now, I know there's a lot of testosterone that we use in women that's younger than that, but we don't have guidelines. So that is part of the exciting things that's happening. And at the moment, there's nothing that one can actually do with the value. How are you going to? That's just always my question. If you test, what are you going to do about it?
No, but
and how will you improve it? So if we can answer the questions, I'm sure it's going to make a difference too.
And that's quite interesting, as you say, because I mean, we are all learning here, and I think I read quite a bit now when the Olympics was about high testosterone in certain women and which boxers wear, and is this one a man, is this one a girl, and it's quite interesting. I mean, the work has been done with the athletes because they've got two definite spikes.
Yes.
This is how the girl should be, and this is how the boy should be.
Yes.
but the fall of where you mix and when to actually start the treatment is quite interesting. So, and with the, like you say, with the boys, that's pretty much been worked out because there's only one hormone and you work it out, and that your peak is somewhere between 200 and 600, and if it's not there, then you supplement.
Women has got about 10% of the level of testosterone that men has got, and that is what really makes it a difficult matter to treat, or how to treat, when to treat. I think I listen to the patient. A lot comes from history and not necessarily from a test.
Yeah, obviously. I mean, we work towards symptoms rather than blood levels, but it's always nice to have a blood level on paper to show someone.
I agree. Why I do blood tests is to have a baseline. So when you treat, you can at least see if there's not a response, or there's maybe a super response. At least you can double check, and show to the patient and explain. So there's value in testing, but I think treating wise, one can go on symptoms.
And if you then test, maybe for our colleagues out there, do you test the free testosterone and a DHEA, or
they work out? They do serum testosterone, they do the sex hormone binding globulin, and they do the lab does a free androgen index for us. That's usually the one that we use. DHEA is not really something that is. I think there's also a lot of work that needs to be done, and to find a good role, for DHEA, it's still open. In future, hopefully, we'll have more to work with.
That's going to be quite interesting. That's a big part of gynecological treatment. There's still a little bit of a black hole.
Absolutely, I think there's a lot. I mean, I'm not here to discuss medical politics or anything like that. But if you think back of what we know about cholesterol and cardiac disease, the main studies has been done on men.
Always,
and we are extrapolating what happens in men to women. And if you think just what you've mentioned about testosterone being the only hormone in men, and there's a pulsatile secretion every 15 minutes, with women, it's a cycle of 28 days. So it's two completely different set of characteristics that you are comparing. We're applying what we know about cholesterol as example, what we've learned from men on women. So I do hope that, and there is a movement.
I definitely think there's a shift towards getting women into research.
Absolutely.
And while you're talking about that, there's a great podcast. We should maybe put a link in that's out this month on Huberman that's actually said how women exercise, feeding and nutrition is totally different to what men is. So, I mean, and you're right, we should not put them in the same.
But that's what we have. So we are doing what we can with the base of information that's available. But I really hope, and we do see it, there is definitely a whole new movement in science to do research on women in terms of all these things.
So, sorry, I derailed you a little bit there with the testosterone question, but we were talking about one of the first things to happen. You said that the testosterone is dropping off, so we can maybe pick up from there again.
Thank you for that, Shaun. I mean, we can go on forever. So by the time in your 30s it starts to decrease testosterone, and by your 40s, you have about the half of testosterone that you had in your 20s. Now, at the same time, with what happens in the ovaries is that the monthly regulated ovulation starts to become irregular. And if you think, I often think that menopause or perimenopause, and we'll touch on that now, is actually nothing else but ovarian failure. And we are all aware, and I'm sure you guys remember from undergraduate studies that we've all learned, we've all been taught about premature ovarian failure, and that's before 40. There's a whole lot of tests and things that we do, but it actually starts early, from 30, 35, 37 onwards. Women can start to have symptoms of perimenopause. And perimenopause is the period leading up to menopause. Menopause is actually the first day of your last menstrual period. Now, no woman will just know that. So we will say that she's postmenopausal if she's not had a menstruation for 12 months. If every time she bleeds, you start to calculate again from the following 12 months. So it's a very academic thing to know exactly when your menopause was. But everything leading up to the last period, your final period, is actually a period of we would refer to that as perimenopause. And even the period after that, until it's 12 months, would be perimenopause. So the transition that's happening in our body. And if it's 12 months after the last period, from there on, one would use the term post-menopause. That's semantics, but sometimes it's important to know these things. Perimenopause is fascinating. It's a transitional period, and it's divided into early, middle, and late. And initially, the ovulation becomes irregular. So what will happen is that she'll start seeing her cycle changes. And that, as I said, can happen from 37 onwards. So it's a very slight change sometimes, just a day longer, a little bit more clots, not always 28 days apart, sometimes 24 days apart, sometimes 32 days apart. So the duration in between the cycle, the cycle becomes irregular. So, or it could be more, or more pain. So there's slight changes that starts to happen, and that's because ovulation doesn't occur so regularly. And sometimes we talk about loop cycles, where there's follicles that grow and produces estrogen, but there is no egg in them, so they're not that fertile anymore. That's why fertility becomes an issue as women age. So from 42 onwards, 42, 43, usually it's really difficult to fall pregnant. And if it happens, it's that scarce little follicle that to escape, and that's available. And it really doesn't happen that much.
So there's a physical change, 37 to 45-ish, somewhere there. And then there's a physical women's parts, and then physical body. Is there changes?
I think so many aspects change. Body odor, hair growth, fluff on your face, skin that becomes drier. All of a sudden they start struggling with acne. So it's skin, hair, vision, hearing.
So
the
I
list
suppose
is so long.
with this process or this continuum, with irregularity, with the cycle, then also there's fluctuation in the hormones, and
Absolutely.
that's causing a lot of the symptoms.
Yes, havoc, and the havoc is the symptoms. It's not just the cycle that becomes irregular; it's all these other things that's happening. And women at this point in time, what I experience in practice is that they don't connect the dots, and we need to advocate and empower our women out there that they start connecting their dots. So many women struggle with mental health in their middle 40s. You've got this difficult teenagers at home. Maybe you're working and there's a lot of stress, and you just experience anxiety. And they don't realize that it's not just life and natural stresses. The hormonal changes also contributes a lot to that. So we really must create awareness around mental health and the impact of hormones on that. Skin, hair, mental health, vision, hearing. The list is just so long. Sleep disturbances. People think that women especially think that they worry at night, they lie awake. But why do they lie awake? It's also associated with the hormonal changes.
And it's not just the hot flushes.
Not always. When you ask them about sleep, they will, when they actually think about it, they'll say, I am warmer than before. And they don't have a hot, a night's sweat where they're soaking wet, but they're not using their winter pajamas anymore. Or their husband should just not touch them, like cuddle in winter like they did a year ago. And they don't always realize that that's part of the hormonal changes that's happening in their body. So there's such a lot of symptoms that we should start talking about. I've actually got a menopausal, perimenopausal questionnaire, about 37 symptoms that patients can have a look at. And start to educate themselves. And I think that's important that we start doing that from a very young age. Become familiar, awareness around your body and how it changes.
And maybe
For me,
that's
it's so
also
important.
something we can link in the show notes to just someone that want to read through it and see where do they stand on that. So,
Yeah, because you can say I don't have it, it's infrequent or it's fairly frequent. In 6 months' time, you can have a look at it again and see where you are. So it's a very nice tool to use.
So some of those symptoms might be very subtle, and it's a long period over which this occur.
Yeah.
But if we replace, then it will get better. So the question, can we improve quality of life replacing?
I believe so, Shaun. We are so scared as clinicians in general about hormone replacement. That's a blanket statement, but I think we became scared a lot after WHI. Like you said, undergrad we weren't taught a lot about this, and 4 years after we qualified, there was the WHI that was published, and it was like gloom and doom when it comes to hormones. So everyone just thought, listen, I'm not even going to go there. So, like I said, the ovaries is the first organ to actually fail in your body. So why should we say, I know it's natural, it is. It's happening to every woman that her fertility decreases and that her ovaries doesn't provide the hormones that she needs anymore. But the hormones are the receptors, estrogen receptors are present in so many parts of the body, in your joints, in your brain, in your gut, not just in the reproductive organs. So when it comes to aging, I really think that the lack of estrogen is hindering women in terms of how they age, and I think we should start rethinking our approach to replacement of these hormones. We don't hesitate to supplement a thyroid when it comes underactive. We don't hesitate to treat a patient with diabetes where the pancreas is failing. So I do think we need to address this. And the decrease in estrogen leads to so many things in your body. It has an impact on bone health. A decrease in estrogen leads over time to osteoporosis. We know that a decrease in estrogen leads to obesity, that horrible abdominal fat, type 2 diabetes, cardiovascular disease in women becomes a problem. And I really think that the whole new approach is something that I quite like, and that is to start with healthy cells, not to wait until you're 60 or 55, but to start early around the beginning of perimenopause, not to wait for full-on hot flushes and night sweats and moods up and down.
So I think with everything in medicine, it's this. I think personalized medicine is the way to go. So you need to see the patient in front of you, what risks they do have, and then make the decision. But glad to hear that we shouldn't be that scared of hormone replacement therapy. But why are we scared of it? What did they say, and where did it come from? I mean, it was all about that Women's Health Initiative in the 2000s.
It's an amazing study if you think that they've recruited 27,000 women. We've just said we'll not include science. So here we have a fantastic group of women that we could assess. From the 27,000 women. So it was such a lovely sample, but the study design was flawed from the beginning. The average age of the women in the study was in the 60s, early 60s, 61, 62. So all the conclusions that they has drawn from there is actually we can't extrapolate to perimenopausal, postmenopausal women in the 50s. With 2002, what happened was that estrogen just got a bad name. It was associated all of a sudden with breast cancer, without a doubt, blood clots, and people really got scared.
Well, also, I think the media also got hold of this story, and they said there was a 25% increase in the risk of breast cancer, which actually that was the relative risk, but the absolute risk was only one in 1,000 women increase. So
exactly.
It sounded much worse than it actually was.
But the study design was flawed, and what happened after that was with this huge set of data, 27,000 women, they had the data, they redesigned the study, and they used the data in a a better way. And what we got from that has really changed. And I think that's what you refer to is the absolute and the relative risk that has been cleared for us now. Chances of getting breast cancer there's much more environmental factors, genetic factors playing a role than hormones, HRT. And I think that's such an important message for us as clinicians and as for our public, women, to know that HRT, hormone replacement, is really not going to give you breast cancer. It depends on your environment. Are you smoking? How much wine do you take on a daily basis? On average, are you obese? Things like that really, really plays a big role, and we need to address that. I think seriously, we should address that and not just always focus on hormones or blame breast cancer on that. Everyone is asking why is there so much younger people getting breast cancer these days, but I do think our lifestyles contribute a lot to that, and we need to create awareness around that. What can be done to prevent that, not just shoot down hormones.
So if we talk about you're going to start someone on hormones, let's say you've had your questionnaire and it looks like you are perimenopausal or maybe in that year where you don't know. So for our clinicians out there, before they start that, do they do blood tests, or can you start someone without blood tests? How do you think about the replacement?
You can start without blood test. I think, like Shaun has mentioned, for me it's all about personalized medical care. Although I'm very fond of hormones, I also want to say hormones is not for everyone. I'll always have an open discussion with a patient. I'll ask her for the opportunity to present it to her, to explain to her how hormones work, how we can deliver it to her oral or in a transdermal way, and to look at risk factors with her as an individual, what is in her life, and then we can start talking. And for me, there's like a personalized toolkit where one should talk about the pharmacological options, but it's so important to address nutrition. It's so important to touch on exercise. Women in the perimenopause needs about 25 to 35 grams of fiber on a daily basis, just to mop up all the extra things in our body that we don't need to be healthy. And to get 25 to 35 grams of fiber in is really a challenge, So start with things like that, nutrition, proteins. One of the symptoms of the perimenopause is sarcopenia, loss of lean muscle. So that's why proper diet, adding enough protein to your diet, and resistance training is so important. For me, it's part of the toolkit, and it's not just pharmacological approach that we need to have. So I do feel we need to talk about those two aspects. When it comes to hormonal management, what I prefer is the transdermal route, and the reason for that is, and that's just my personal opinion. Oral options, there's plenty of them to choose from. It's all about safety. So after WHI in 2002, a lot of work has been done, like I said. But in 2019, there was a study published, open access, in the British Medical Journal that compared the risk of getting a VTE, embolus or a DVT, on transdermal hormone delivery or oral. And not a single patient in the transdermal group had VTE. So it's a safe route.
And do you think it's the first pass effect of going through the liver?
With all your clotting factors that's involved. So I had a pulmonary embolism in 2013. So believe me, I couldn't find a reason for that. From 2013, I've been on hormone replacement therapy because I was so scared. At that point in time, it was a no-go for me. And I thought, how am I going to age? So I've been studying and tracking these changes for quite a while now. So I like the transdermal routes, and the new estrogens that's available in 17 alpha estradiol. And the reason I mention that is it's actually what we refer to as a body identical or bioidentical hormone. So it's like the hormone in your body. It's not a synthetic estrogen like we find in most of the, or many of the oral contraceptive pills. So it's a very safe molecule that's delivered to your body, and you apply it on your skin.
Any doctor can prescribe that.
Any doctor.
It is available in the pharmacy. You don't have to compound it.
We have a gel available that you can apply on the forearm in a hairless area once a day, usually in the morning, or you can use a patch, estrogen patch, and that's available twice a week. You apply the patch. Now, if a woman has got a uterus, it's so important to remember that we need to protect her endometrium. So with a uterus intact, you have to give a progesterone. And when it comes to progesterone, it's important to think about the delivery of your progesterone component. The synthetic medication is called progestins, and they were the ones used in the WHI, and they are actually the ones that we are very skeptical about. But the micronized progesterone is also body identical. So I aim for that. So you have a combined oral pill that contains a micronized progesterone and a 17-beta estradiol that you can use on a daily basis. Or you can use a patch or the gel, and you can use a micronized progesterone at night as a tablet. And the dose for that, if it's continuous, should be 100 milligrams at night, and then 1 or 2 squirts of the gel or a patch twice a week. So that's how I usually start hormone replacement. The option of inserting a Mirena is also that in the Mirena we have levonorgestrel, which is the 3rd generation progesterone that has very little side effects. It protects your endometrium, and it's not actually available in the rest of your body. The action is mainly in the endometrium. That's why I like that as a form of contraception, because it doesn't suppress your ovulation. So if someone wants to have, back to your contraception question, if someone wants to feel natural, they don't want to have that ovarian suppression that comes with a pill, a Mirena is actually a very good option, because you control the bleeding, but she still feels like herself with her monthly ovarian cycle that happens. So in terms of hormone replacement, we can use the Mirena for a period of 5 to 8 years, and then add estrogen in an oral form or in a patch, a transdermal gel.
And do you monitor blood levels, or you just go on symptoms?
We go on symptoms. If they have like a breakthrough bleed or struggle, especially with bleed, or there isn't symptom control, it's so important that when you start hormones that you follow them up. Mm-hmm. And I prefer you can do that virtually, by just having a chat with them, filling in the questionnaire again, just check where they are 6 weeks after you've started, and usually 3 months after that, just to check in and see, do we get what we want? Are we achieving what we want to achieve? And then if especially if I'm a transdermal or sometimes an oral, and if the response is not what I expect to happen, I do a blood test to see if they actually absorb. And that's where a blood test will.
And that would be nice to have the baseline.
That's exactly. That's why I do a blood test as a baseline, not to diagnose. Symptoms is diagnostic.
That's quite interesting. It's very much the same with the men. We start them because we've seen the blood test, but we also test them on giving transdermal testosterone, and we also measure their symptoms more than, because the amounts we give won't shoot them over the top like a bodybuilder. They just get, but it's very much the same. Just get you to who you were.
Yeah, that's the thing. They often tell me, I just don't feel myself. You start them on estrogen, they come back and say, I've got energy again. I feel like myself. I know I can do things again. I've got the confidence to do things again. And it's really amazing to think that a little molecule like estrogen has got that impact on a woman's being. It's much more than just reproductive health, responsible or influencing much more than just reproductive health.
And that's quite interesting. I mean, if you follow the longevity stuff from the USA, they pretty much say menopause as we know it should not happen anymore. The women should stay women. Yeah. So I mean, but we talk about menopause as the menstruation stopping. But a woman should stay a woman for long and have the protection and have who they were. Like,
Exactly. That's why, for me, the old school of thinking that it's part of natural aging is not valid anymore, because women don't die at 60 anymore. They don't die at 40 anymore. They live long, 80, 90, and even longer if you look at the people in Japan.
Yeah, and you look at quality of life.
Yeah.
I mean, that's the important thing.
Yeah.
I mean, we started this podcast with pretty much thinking two things we want to protect: the brain and the muscle. I mean, all the other things you do is to try and be strong when you're older. So we're thinking you have to protect the brain and the muscle for the 80-year-old. So that's our aim. And what you're saying is exactly that. You're going to protect bone that'll carry the muscle. You're going to protect who you are, brain function. So
Look, it's important to realize that we cannot claim that hormone replacement will prevent dementia, but it definitely have an impact. We haven't touched on the word brain fog, but it definitely it's a brain hormone. Estrogen receptors in your brain, testosterone has an influence on your brain, so it does have a good impact or the influence of hormones on brain function is definitely something we're also going to see in the future. There's a Dr. Lisa Mosconi that's big on social media. She's written quite a few books, and she's worthwhile following. And she's research based, and her stuff's good. She's doing a lot of work on brain and hormone replacement therapy and menopause and all of that. So there's definitely things happening.
Well, we know Alzheimer's, we've got higher incidence in women, and especially women that had a pre or early menopause, there's even higher incidence of dementia in them. So it looks like there might be a link.
Yeah. That's the thing. I think within the next 10 to 15 years, 5 to 10 years, I'm optimistic, I think there's going to be a shift. Even in 2020, just before COVID, I think it was February of that year, the American Cardiac Association published a statement on the importance of hormone replacement therapy, and they've started with a campaign to make cardiologists aware of the positive impact that estrogen has on cardiac health. And somehow that message is still not filtering through to our GPs, our gynaes, our societies. And there's a whole drive or awareness that's at the moment being created.
20-year curse of the 25% increase. I mean, it's still lingering there. That's what people heard.
Yeah. So there's a lovely book that has been written. If women wants to read it, and these days it's so easy to read books in online as ebooks. It's called Estrogen Matters, and it explains. There's a version coming out now in September this year, or just an update, and it explains the WHI and why we should not be scared of estrogen in such a nice layman kind of form, and it's really reputable people that has written the book. So Estrogen Matters is something that our listeners can really.
And I think the other thing as well is with estrogen and testosterone on bone density. I mean, if we look at people above the age of 60, one of the biggest factors for mortality and morbidity is still falls and fractures. So I mean, that plays into that part of the equation as well.
Yeah, but touching on that, I think adding hormones to your life give women their life back. So that's why I think use it by improving nutrition, by starting, and I always advocate young mothers to not neglect an exercise routine. If you can only do one exercise set a week, at least you are doing it. The importance of starting with Pilates or yoga or early on is, and you don't need an hour in the gym every single day. 7 minutes of resistance training will make a difference on the long run. And there's such nice things available these days online where you can really use 7 minutes with tins of baked beans in your house to do, or a bag of sugar.
I suppose when we talk about exercise, that's exactly what people think. They think, I need to go to the gym. But that's not the fact. You don't need equipment to do resistance training. You can use body weight exercises and things like that. You don't even need to set time aside for that. You can work it in your regime, like in the morning when you make coffee, do a couple of squats.
Exactly.
While you wait for the coffee machine.
Brush your teeth too.
Exactly. So there's ways to get around that.
Yeah.
But it's so important.
Multitask. Yeah. But pay attention to mental health. I think that's also quite an important part of menopausal treatment, just to get back to that, the whole toolkit. To be aware of your mental health, to be mindful about where you are in your life, what's happening, and linked to that for me is sleep. I think
the superpower.
It's a superpower. I like that. The thing is, we're so addicted to our phones or to mindless watching of television, Netflix series, things like that. We cannot expect miracles if we have bad habits, and changing habits is one of the difficult things. But I sometimes think that prescribing a sleeping tablet is so much easier. A half tablet every night, every second night, it's so much easier for a patient. But if you don't address sleep hygiene, what's the point?
So we've actually touched on our previous podcast exactly that. So exercise, we say 80% of what you can fix in the human body is exercise. So we've got that one. I think aligns very, very well. And I think the other thing that is also sleep. We've touched on. So with the work of the Matthew Walkers and those guys, how important that sleep is. I think my biggest learning point today is that we are learning so much that it's changed so much and I'm just wondering how far other people are behind, because we think we are actually bashing down the door, and I'm learning so much. So I'm just thinking about our colleagues and the people out there, that they must understand that there is better ways.
I think it's why I really appreciate us talking about hormones and hormonal health is we need to empower our women and men, but empower our public out there to become involved in their treatment plan, in their personalized care. And if we can give them tools and the knowledge, then they know how to ask, what to go for. And that's important. But it's a whole lifestyle that you need to address.
I also think it's like this instant gratification of the current times, is that take a pill and I'll be better. And not willing to put in the time and the effort, and results come over time. So
Absolutely.
You need to work on it. You need to be part of the whole plan. It's your life. How do you want to age, and are we going to work on this?
And on that, Shaun, when you start a woman on hormone replacement, always tell them 3 months, minimum of 3 months of treatment before they say it's not working for them. The first 6 weeks is the hardest, because you're so depleted of estrogen, and all of a sudden your body gets estrogen back and it doesn't know what to do. Mm-hmm. So you have to. I always explain to them that first month is really going to be challenging. I think it's going to be like that for you, but you will see as you carry on. You will feel better, and you will see results. So the perspective of what patients expect is important, especially in our world where instant gratification is so
prevalent.
Yeah.
So I think the next big question then is, when do we stop it? Do we know? What do we think about it?
With the woman's health, if you were on it, you definitely stop on the day that you turn 65. 65, you stop it. And that is a random age. There's no science to tell us that it should be like that. So lately, the new trend is to, once again, individualize. Change what you are giving to her, change the dose, see what she needs. Sometimes on a patch, you get 5 strength of patches, from 100 to a 25, 5 different that you can choose on. If she's on a 75, bring her down to a 50 and see how she's doing. Change the patch not twice a week after 60, 65, but once a week. Let her be the one that guide you with that. So the answer at the moment is not to stop until the patient maybe forgets to take it, and she feels okay. The one thing that we haven't touched on, and I know we're not going to spend so much time on it, is never forget about vaginal dryness. The oral or the transdermal estrogen doesn't always get to the tiny little corner of the vagina. So it is totally acceptable to prescribe estriol cream, vaginal cream, to a patient maybe once a week or twice a week, depending on the
That's
needs.
also on replacement.
Although she can be on replacement. And with that, the whole genital symptoms of menopause, the GSM, I struggle with that word, GSM, so much shorter. The thing is, older ladies, they lose the protective barrier in their vagina, and it leads to recurrent UTIs. And that leads to visits to the GP and antibiotics, and doesn't clear up, and antibiotics, and you break down the immune system. And prevent it by rather treating them with the estriol, the E1 cream. That's so safe. It's a 10 microgram cream that you give to them, and that holds up the barrier and prevents blood infections, recurrent blood infections in future. And of course, it has a positive impact on not having painful sex, which could have an influence on a woman's libido.
And will you give that to everyone or individualize
You listen,
again?
yeah. But just be aware that when to ask about that, if she experienced any pain during penetration.
And
Burning,
is that one of
especially.
the 37 questions in your questionnaire?
Yes.
Okay.
It is.
Yeah, no, I mean,
The thing is,
because
if you use the questionnaire, it makes it so much easier to give the patient permission to speak about this. And I think that's the whole thing around sexual health. Is
You
that
only
we
see
need to
what
give,
you look for. So.
Yeah, you have to give yourself permission and the patient permission to speak about difficult things like dysbieutin.
Just for the sense of what we do, so we hardly see a client in our InnerSight assessment. So I think that would be quite a nice thing to send out, because our first forms of how you check in is actually just on your phone. You just go boom, 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 answer, and there it goes. So if we can have that 37 questions before, that would be quite cool in a data model to go.
Absolutely.
Your chances of being in menopause is that much, or that'll be quite an interesting exercise.
Yeah, it's available, and it really helps. Well, it helps us as clinicians, but also our patients to create awareness. So I'll share it.
It gets better to you get to ask certain questions. So it's nice to make use of questionnaires. We use it a lot. We use it for sleep apnea. We use the Adams score for things, and it helps.
Yeah. It's standardized. It's proven. It's stood the test of time. So why reinvent the wheel?
Yeah. Talk about busy. You are probably very busy, so a lot of people are going to listen to this podcast and go, "How do I get help?" So obviously, I'm not sure if you take on any new patients, but is there a society in South Africa, or where would we guide people? I mean, if they don't come to us or try to get to you, where do they? I mean, except for reading
for us, it's easy. We phone.
I do take on new patients. I have a busy practice, but we're not that busy. It is not as busy as what I was when I was obstetrician. It freaked me out if I was 4 months ahead. I really didn't like that. So now it's not that long a period to wait. But the answer should be that your GP should be able to help you with this.
Yeah.
Most gynaes will be able to assist with this. Maybe not in exactly the way I described it, but I mean, that's why if we can empower our women about the toolkit and at least give them an idea of what's available, they can ask the right questions to their gynae, and they can get the treatment that they need, personalized, according to their individual risk. So,
Brilliant.
and there's a lot of information. You've asked about a society. South African Menopausal Society is available, but the International Menopause Society, actually on YouTube, has quite a lot of videos. That's nice to watch. I think this book that I've mentioned, Estrogen Matters, is a great book to read for anyone that's interested in or scared about a risk for breast cancer and association with HRT. Other book that I really like a lot is The New Menopause, that's been written by Dr. Mary Claire Haver. That's been, I think, published in April. So there's a lot. And all of these people is they're on Instagram and TikTok, and there's really good information out there. Another woman that I follow on social media is Dr. Corinne Men, and why she's interesting to me is that she had breast cancer at the age of 28. So the way she looks at science and what's happening is totally different. It's like me looking from someone who's had a PTE. So your interest is different. So yeah, there's really nice voices out there these days that's educating our patients about HRT. And I think, for me, it's just so important. Every woman deserves a conversation about hormone replacement therapy. And you don't necessarily have to take it, but at least you deserve a discussion around it. And the opportunity to raise your concerns or ask your questions. I think that's the least we can do as doctors. And it should be managed by general practitioners. And the interesting stuff, or not interesting, but the more complicated stuff should come our way. Or at least be a discussion between a specialist and yourselves. I mean, I'm willing to assist. It's really not rocket science.
I suppose the problem still is time constraints in a GP practice.
Yep.
Because this is a conversation with someone that's going to take you an hour.
There is. I've told you, I book a patient an hour for consultation like this or a discussion like this, and sometimes we go more towards 90 minutes because once you start talking, it becomes they start to realize what's happening in their lives and they start to put everything on the table, so it is time consuming, but it's such an important conversation to have. And once you've had it, the follow-up after that is not always so time consuming. So it's worthwhile spending the time. That's I think one thing that I do find amongst women in this age group from 35 to 55 is that children is still such a big priority and their own health. Men, I think, actually take care of themselves in a better way in that age group. And I think women still don't prioritize themselves enough before it's actually too late. So ideally, we should have this conversation long before 55.
It's quite classic what you're saying. We see men have done nothing to their health and then suddenly at 40 go, I want to be screened. Where am I? Whereas we see the women have been looking after their bodies so well, probably because they wanted to have children. So they have gynaes and they have... But then, as you say, they don't screen. Onwards. So we normally see the women come through us after their men have had their screens. It's quite interesting. And it's exactly what you're saying.
You lose them in your practice. You deliver their babies. And then after that, you lose them for, say, 15 years. And all of a sudden, they pitch again. And then you have to open the can of worms and start. And that can be quite intense. And it's so important to keep up with screening. I believe we're going to age well if we make the right decisions for our health. And it's not just medication that's going to be the trick, and that's what you guys have been speaking about. It's a lifestyle that we need to address.
And that's why it's so great having you here, is having the conversation with for the ladies to say that there's something new out there and that they should have conversations. It should be tea time conversation or around MCC or whatever. Have you had this conversation?
Well, while walking in the neighborhood. Skip on the alcohol.
Yeah.
Such a catch-22, this alcohol and the role play. It's a hard thing to deal with, but 2 glasses of wine a day, 2 glasses of wine is too much. Yeah. And women don't realize that because we don't talk about it. It's the same about being obese. It's really detrimental in so many ways. So exercise for me is really key in this whole conversation and addressing social habits.
Thank you very much.
Yeah, excellent.
Marlena, it was great having you here. I, again, have learned a lot. So every time we have someone We think we know a lot, but then we've learned a lot. So thank you so much for coming in.
You're welcome. It was such a pleasure having this conversation with you.
Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.